about 80% of the patients in our trial are alive at 3 years, when you would expect in certain stages. We included stage 3 patients. Stage 3 patients, it's only about 40% that you would expect to be alive at 3 years. So we're pretty excited by that.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is David Carbone. David is a lung cancer expert, and he is the director of the James Thoracic Oncology Center. He's been on the podcast before, and the last time David talked about how there were a few new immunotherapy drugs in development. Today, we're going to talk about one of them, a drug that was part of a clinical trial here at the James that David led and has shown really great promise in treating before surgery, that's the key, before surgery, patients with non-small cell lung cancer. David is also a cancer survivor, something we talked about on a previous podcast, and because of his treatment, he has a little bit of scarring in his lungs and might cough from time to time. So I just wanted to warn people that's what's happening, and it's all part of cancer treatment, things he's working to make even better. So welcome back to the podcast.
Well, it's great to be here, Steve. Happy to do it.
Thanks for being here again. You're getting to be a regular. David, I thought we'd start with just a really quick briefing on the difference between non-small cell lung cancer and small cell lung cancer, and which one is more prevalent.
So those are the two main categories of lung cancer, and non-small cell lung cancer is the majority of cases. It's perhaps 80% of all lung cancer. And it's a huge clinical problem in the United States. There's around 200,000 cases of it a year. And unfortunately, only about 20% currently are surgically resectable. In other words, can be removed by a surgeon completely and safely. And the rest are either locally advanced or metastatic.
Okay, so that brings us up to this new drug, which is hard to pronounce. How do you say it?
Atezolizumab.
Atezolizumab. So
MEB.
I'm not even going to try.
at the end.
I'm going to just call it that new drug.
Atezo is what we
Atezo. There we go. I can say that. Atezo. So give us the background and walk us through this clinical trial and why I'm fascinated by this pre-surgical angle and how that's going to improve things.
Right. Well, even if you can surgically remove the entire tumor, about half of non-small cell lung cancers that are able to be operated on still recur, and patients die of their disease. So there's a real need to improve outcomes. And for many years, nothing has been available that improves that outcome. We've been using chemotherapy after surgery routinely, and that improves survival by only about 5%. But this new class of drugs, the immunotherapies, there are now many such drugs out there, have shown dramatic benefit in metastatic disease. And so we decided several years ago to test their efficacy in surgically resectable disease. But also, as a laboratory scientist, I'm very interested in studying why some patients respond and others don't, and how we might get more patients to respond. So I thought the ideal setting to not only test clinical impact, but also to study the biology of the response to this class of drugs is to do it before surgery, because you can get samples of the tumor before and after you've treated with the drug, samples of blood from before and after you've treated with the drug, and you can correlate molecular features with the response that you can observe at the time of surgery and also by CT scans. So it started out as a proposal of mine that was very limited in size, but then in conversation with the companies, they decided to make it a national trial that we led, involving about a dozen institutions across the country.
The companies will be the pharmaceutical companies that made this drug.
And that's Genentech Roche for this drug, correct.
Okay, so again, what happens next? You have this idea to give it to patients before. What happens when you gave it to them?
Well, so we first of all discovered that it was safe. That's the paramount importance when you do anything, especially in patients who could be cured by surgery alone. We wanted to make sure it wasn't interfering with the surgery. But we also found that in 20% of patients that we treated, there was less than 10% viable tumor left at the time of surgery. And in about 7% of the patients, this was a 183 patient trial, in about 7% of the patients, there was no tumor left at the time of surgery after just 2 doses of this drug given before surgery. And that was a gratifying result. And we just recently reported the survival data on that study, and the survival stage for stage, patients on that study at a 3-year time point is almost double that of what would have been expected from historical controls. So that's very exciting that we not only have measurements of benefit by amount of tumor at the time of surgery, but we seem to be seeing a dramatic clinical benefit in terms of many more people alive than you might have expected.
Wow. So let me go back to 2 things you just said. The first is you had the percentages you gave of people whose tumors shrunk almost completely and some even completely. Was that even better than you had thought or hoped for going in?
We always hope for 100% benefit, but it's certainly better than what you see with chemotherapy. And so that was exciting.
And the second point is, how long ago did the clinical trial start, so we can get a sense of how long patients are out from their surgery?
Now, we're just getting to a 4-5 year follow-up kind of time frame. So the trial really was initiated about 5 years ago.
Oh, okay. I didn't realize it was that old. That means, so that 3 to 5 window where so many of these people might not be here, they're still here because of this clinical trial?
Yeah, really about 80% of the patients in our trial are alive at 3 years, when you would expect in certain stages. We included stage 3 patients. Stage 3 patients, it's only about 40% that you would expect to be alive at 3 years. So we're pretty excited by that.
That's pretty amazing. And when we talk about like 80%, these are actual people that many of whom you know.
Yeah, well, many of them were my patients.
Yeah.
And this was a complex effort because of we really wanted to collect these biospecimens. So we did this at academic institutions around the country. And we're able to get some very interesting molecular studies on these patients. And we have 5 or 6 papers that are in preparation, in addition to the 2 that have already been published on this work.
All right, we're going to take a quick break, and when we come back, David will tell us a little bit about some of these papers and what this all means and how this drug works, and maybe what's next in some new clinical trials.
Well, happy to do it.
You didn't choose cancer, but you can choose where to treat it.
And when you choose the James at Ohio State,
you're picking a team of experts who understand there is no routine cancer.
You're opting for care from a highly specialized team dedicated to treating one type of cancer, yours.
A team that studies the unique makeup of your disease to develop a personalized treatment plan.
You're choosing our region's only comprehensive cancer center designated by the National Cancer Institute.
Where more than 1,700 scientists are working on new treatments and new hope for every form of cancer.
At the James, you're making the choice to have the most advanced treatments, many of which were developed right here.
And you're choosing access to the James world-class clinical trials, dedicated support services, and an unmatched survivorship program to support your life after cancer treatment.
You didn't choose cancer, but the choice of where to treat it is clear.
We're back with David Carbone, director of the James Thoracic Oncology Center, and we're talking about a new drug, atezo, that's showing great promise in patients with non-small cell lung cancer who are being treated with it before their surgery. So, David, how does this drug work when it's in the body? What does it do to help the immune system shrink these lung cancer tumors?
So atezo is one of a class of about a dozen drugs that are now in study or on the market that block a pathway called the PD-1, PD-L1 pathway. And this was discovered, and actually this pathway was the basis of a Nobel Prize that was recently given out. But what was discovered is that cancers overexpress this protein called PD-L1, which binds to the other protein, PD-1. And when cancers overexpress this protein, they turn off any immune cells that are coming in to attack the cancer. So the immune cell that would otherwise come in and kill the cancer sees this protein on the tumor cell, and it gets turned off, and it just wanders off and doesn't do anything. So these drugs block that PD-1, PD-L1 interaction, and suddenly the cancers say, hey, there's the immune cells say, hey, there's a cancer here, we can kill it. And a lot of things that sound good in theory don't work in practice, but this actually works in practice, and we have many patients that are alive today that wouldn't be without this class of drugs.
So this atezo goes through the body. Is it through an IV? Or
it's an intravenous antibody. It's not a chemical that blocks the receptor ligand interaction.
So it finds these cells. How does it know how to find these cells in the lungs?
It just percolates around your body, and
it goes everywhere.
It goes everywhere in your bloodstream, and wherever it sees one of these PD-L1s, it binds to it, and that keeps it from inhibiting the T cells.
And so the cancer is no longer hiding; it's visible. The immune system says, "Let's go."
It's like turning off the force field on the Starship Enterprise.
Oh, the force field analogy. You used that before. I remember that. Okay, so you've given a patient atezo. Their lung cancer tumor has shrunk or been eliminated. You still do a little surgery. What happens after surgery? Is there, in the past, people still got chemotherapy, or I'm not sure, maybe even immunotherapy? What happens now?
Well, no, the immunotherapy after surgery is very new. It's just very recently, in the last few months, been approved by the FDA. But historically, since I began my training 30 years ago, people would use chemotherapy in patients at high risk of relapse. And that really only resulted in about a 5% improvement in 5-year survival, which is not acceptable.
No.
And why we're trying to do these kinds of studies.
So what does this mean? Put this in the big picture perspective. If it's a clinical trial, so there's still work to be done and lessons to be learned. But if it keeps advancing and doing what it's been doing, and you hope it's going to be doing, what does that mean for non-small cell lung cancer patients down the road and outcomes for them?
Well, I think with the recent approvals and the new trials that are going to be reporting out in the next couple of years, in addition to ours, I think immunotherapy will become a standard part of care for most surgically resectable lung cancers.
But this concept of getting it before surgery, someone else talked about that might be happening soon in breast cancer as well.
That actually has been going on for a long time in breast cancer. This is a new immunotherapy before surgery is a very new concept in lung cancer.
But overall, with all cancers, it sounds like that's a trend that's growing, but you're still in the early stages trying to figure out which cancers, which immunotherapy drugs, and things like that.
Yes. So immunotherapy has found a home in many types of cancer therapies right now. It's probably most active in melanoma and lung cancer, but other types of cancer, it's shown some activity as well. But in all of those situations, it doesn't work in everybody, and yet we give it to pretty much everybody. So, as I said before, one of the important features of this trial was the science behind the trial, and And I'd like to tell you about at least one of the pieces of science that we found in this study that's really exciting too.
Yeah, definitely, because I think what you're going to tell us is why it works in some people and why it doesn't, right?
Well, so the best clinically useful piece of information would be is if you could tell before you gave the drug to a patient whether it would work for them or not, or whether it would just have the toxicity and not work. So we looked very hard, and we are continuing to look at the data from this trial. But in our original publications, which came out a month or so, a few weeks ago in Nature Medicine, we found that from pre-treatment blood sample, take a blood sample before the patient gets any treatment.
Blood sample, not a tumor sample.
Blood
so that's
sample.
Easier.
We were able to assign to that patient a probability of response to atezolizumab, and that because the study was pretty large, we were able to develop that signature in part of the patients and then test it in the rest of the patients, and it held up in the rest of the patients. So to me, it's very exciting that we may be able to have a blood test that predicts whether these patients will respond to immunotherapy. Now, we don't know if it's specific for atezolizumab, so we're in the process of planning for further studies to test it in other settings. We don't know if it applies in metastatic patients treated with immunotherapy. But the other exciting thing about it is that it identifies certain cell types that are associated with lack of response, and they have certain markers, which very excitingly, those markers have independently been discovered as potential therapeutics for lung cancer. So we found several markers on these cells for which drug companies have already developed drugs, and would suggest that maybe we can identify a class of patients not likely to respond to atezo, but possibly more likely to respond if you add new drug plus atezo. And so it's not just telling people they'll do badly, it's giving them something to hope for to make them do well.
And as more immunotherapy drugs are developed, there'll be more options for people that atezo doesn't work for, this immuno doesn't work for. You'll have 8 or 9 or 10 or 20 options, and you'll find the right one.
Well, and I'm hoping this is a generalizable observation, because all these drugs block the same pathway. And so atezo is just one of, like I said, a dozen drugs targeting this pathway.
The PD1
and PD-L1 inhibitors. And I'm hopeful, but it needs to be tested, that our findings will apply to all of those drugs, that whole class of drugs, and suggest novel combinations based on science rather than just guesswork, which is what we're regressing to now.
And when you say you take the blood and look at it, you're looking at the genetic.
Actually, it's cell surface markers. It's by a technology called flow cytometry. So that result was a flow cytometry assay. But we did all the genetic markers. We have fascinating results from genetics and the transcriptomics and T-cell receptor analyses that I can't go into. It's just too much data, and we're preparing the papers now.
But it's this concept of personalized cancer care for each patient as each month and year go on, and each new drug and clinical trial, you're finding what works and why, or what doesn't work and why for each patient, and being able to dial down and give them the exact right medicine.
Well, that's what transformed lung cancer care 15, 20 years ago with the targeted therapies, matching a specific therapy to a specific genetic target. And that's made a tremendous difference in those patients. But with immunotherapy, we tend to use the same treatment for everyone. Everyone who doesn't have a genetic target gets immunotherapy, and they get the same immunotherapy. And I think that's, from a scientific perspective, very unsatisfying. That there are the immune system is so complicated, there are many ways that cancer can avoid the immune system. We need to really study cancers in patients that respond and who don't respond, and figure out why Jane Doe responded and John Smith didn't, and tailor the immunotherapy to their particular molecular features. And our trial is a step in that direction.
Wow, because you said you found the old method unsatisfactory, so you decided to create a new method.
We're working on it.
There you go. What's it like? Because you've been in this, doing this long enough that you, 20, 30 years ago, you had patients you couldn't do anything for. And now, what's it like?
Well, the dinosaurs don't get in our way today like they did when I started.
Okay. You started practice on Jurassic Island.
Yeah, Jurassic Park.
Oh, yeah. Jurassic Park. But
no, it's true. When I started over 30 years ago in lung cancer, most patients didn't get treatment at all. They just got pain control and pats on the back. And their median survival of all stages of lung cancer put together was about 6 months.
Wow.
And now we're seeing subsets of patients, and well, like I said, in our study,
Yeah,
80% alive at 4 years.
But the people coming into the study don't know all this. They don't know about this new drug. They don't know what you're doing. So their mindset coming in might be not that positive. And it's like, all right, this is like a Hail Mary pass. And you're able to tell them, no, we actually have a really legitimate shot of giving you some quality of life for a long time.
Most of our patients are metastatic at diagnosis, about more than half. And I used to tell them right on our first visit, after I explained things as best I could, that their cancer is incurable, but that doesn't mean it's untreatable, and that we can make their life longer and better. But now I'm telling people that there's a small chance that they could be cured even. And I just had a patient in my clinic the other day who started in 2014 and finished 2 years of immunotherapy and has been many years off of immunotherapy, still has no sign of recurrence after being diagnosed with metastatic disease. And so this doesn't happen in everyone, but we can give hope to our patients that if they look in Google online, they may think things are hopeless. But we really do have new hope for our cancer patients because of these types of therapies.
Yeah, and down the road, there's going to be even more hope as you keep working on these new clinical trials.
We're keeping at it.
All right. Well, thanks for sharing all this great information and good and news. And come on back when you have some more good news.
Happy to do it.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.